Fundación Cana brings you the following article. Cannabis and Chemotherapy by Cristina Sanchez, scientist and lecturer at Complutense University, Madrid, Spain. Increasing numbers of people are turning to cannabis in search of a complementary or alternative therapeutic option for treating their ailments. One of the questions they most often ask is whether they can use cannabis while undergoing conventional treatments. In the case of cancer patients, the specific question is whether cannabis can be used during periods of chemo, immuno, hormone, or radiotherapy. Unfortunately, not enough clinical trials have yet been conducted to allow for a categorical answer. In these circumstances, patients are faced with the option of waiting for the results of high-quality clinical trials without even knowing who might be willing to conduct such research or when, or weighing up the known and potential risks and benefits and act in consequence. In this article, we shall try to summarize the information currently available to allow patients and doctors to take the best course of action for each individual case. Medical use of cannabis in cancer patients. Cancer patients look to cannabis with two different objectives that are not necessarily mutually exclusive: to alleviate the side effects of the cancer therapy and to achieve anti-tumor responses. With regard to the first of these goals, THC has been clinically demonstrated to prevent the nausea, vomiting, and loss of appetite caused by chemotherapy. In many cases, the adverse effects are so severe they lead patients to abandon the treatment. Cannabis has also other well-established properties of great benefit to cancer patients, as an analgesic, anxiolytic, and a sleep inducer. More recently, people suffering from cancer have also turned to cannabis for its supposed anti-tumor effects. While it is true that certain cannabinoids have been shown to have responses of this kind in different animal models of cancer, there are as yet no controlled clinical trials to corroborate these observations in humans. Nonetheless, due to its high safety profile, thousands of oncology patients throughout the world use cannabis to try to halt the spread of the disease or even eliminate it altogether. In either of the two cases, palliative or anti-tumor effects, one of the first questions patients ask is whether it is safe to combine conventional therapy, chemotherapy, immunotherapy, hormone therapy, or radiotherapy with cannabis. What does the preclinical research suggest? Experiments conducted in recent years on tumor cell cultures and with animal models of cancer suggest that a combination of cannabinoids and standard anti-tumor therapy might work better than either of the two approaches on its own. A large percentage of cancer patients receive chemotherapy. This treatment targets proliferating cells in the body, attempting to block their division and cause their death. This can be achieved by means of several general strategies. The most common is to interfere with the process of duplication of the genetic material in the cells and to block reorganization of the cytoskeleton. The internal scaffolding which gives form to the cell allows it to move and governs the physical separation of the two daughter cells in cell division processes. There are a variety of tools for blocking the DNA duplication of the tumor cells. They include compounds incorporating alkyl groups, such as temozolomide, bridges between DNA chains, such as cisplatin, analogs of their structural components, such as 5-fluorouracil or 5-FU, and inhibitors of the machinery which maintain the topology of the DNA during the cell division process, such as irinotecan. Preclinical studies show that cannabinoids not only do not hinder the anti-tumor action of members of many of these families, but actually potentiate it. For example, 5-FU reduced the viability of colorectal cancer cells in cultures far more effectively when combined with the cannabinoid agonist HU210. Along the same lines, Guillermo Velasco's group at the Complutense University have described how a combination of temozolomide and delta-9 tetrahydrocannabinol in an animal model of glioblastoma causes a greater inhibition of tumor growth than either of the two treatments on its own. As for drugs that target the cytoskeleton of the dividing cells, paclitaxel has been demonstrated to have synergic effects when combined with the endocannabinoid anandamide. In a cell model of stomach cancer, a combination of the two compounds caused greater cell deaths through apoptosis than either of the two compounds on its own. As well as chemotherapy, many cancer patients receive radiotherapy treatment. This involves exposing the tumor cells to high-energy radiation to cause alterations that will halt cell division and induce their death. As in the case of chemotherapy, there is preclinical evidence to suggest that cannabinoids might sensitize tumors to this type of treatment. Scott and collaborators, for example, showed that a combination of submaximal doses, i.e. doses that exercise very discrete anti-tumor effects in themselves, of THC plus cannabidiol, CBD, and radiation, caused a dramatic reduction in the growth of glioblastomas generated in mice. What research in humans says. To date, only one clinical trial has been conducted specifically to analyze the combined effect of cannabinoids and an anti-tumor drug. This trial, conducted in hospitals in the UK and Germany amongst patients with recurring glioblastoma, analyzed the safety and effectiveness of combining temozolomide and Sativex, a cannabinoid drug containing approximately the same amount of THC and CBD. Although the results of the trial have yet to be published, a press release by the promoter, GBW Pharmaceuticals, appears to indicate that there were no negative drug interactions. Even though this is the only clinical trial designed specifically to analyze the safety of combined treatments, it is important to note that many trials have been carried out with medicated cannabinoids on oncological populations following conventional anti-tumor treatments. For example, with Sativex alone, 7 clinical trials have so far been carried out to analyze its effect on oncological pain among cancer patients. None of the subjects reported negative interactions between the medications. Likewise, no negative effects have been detected associated with the combination of drugs in other tests performed to analyze the analgesic effect of cannabinoid drugs in cases of neuropathic pain caused by the chemotherapy itself. Finally, it is important to remember that one of the very few authorized medical uses of cannabinoid drugs is for the treatment of nausea and vomiting caused by chemotherapy. In principle, at least, this suggests that the combination of the two therapeutic strategies should not cause any problem. Precautions. While it is true that the accumulated preclinical and clinical evidence to date suggests that cannabis may be used safely in combination with chemotherapy and radiotherapy, there are a number of issues that still need to be examined in greater detail. One of them is the possible interference of cannabinoids, especially CBD, with the cytochrome P450, CYP, detoxification system. This system is responsible for metabolizing many different compounds, including many of the drugs we habitually take, oxidizing them and thus transforming them into metabolites, which are non-toxic for the body. It has been described that both THC and in particular CBD are capable of inhibiting certain CYP isoforms, which might increase the half-life of the treatments processed by these enzymes as a result of the non-metabolization of the drugs. Other compounds used by these patients, such as tamoxifen, are administered in the form of prodrugs, which only activate when processed by CYP. Thus, the combination of these prodrugs with cannabinoids could, in principle, reduce the bioavailability of the corresponding active forms. Finally, many of the drugs used by cancer patients, anti-tumor drugs, antidepressants, stomach protectors, analgesics, etc., inhibit the CYP system, which is also responsible for detoxifying both THC and CBD, and therefore the simultaneous use of cannabis and those drugs would increase the half-life of the cannabinoids. However, none of these potential interactions appears significant enough to advise against the combined use of cannabis and other therapies. Firstly, the inhibition of CYP in vitro by THC and CBD occurs at very high concentrations, above the maximums observed in clinical trials. Secondly, as yet scanty clinical experience suggests that such interactions can easily be managed by making small alterations to the dosage. For example, A potentially negative interaction has been described between CBD and clobazam onfi, a benzodiazepine that is used as a coadjuvant in forms of epilepsy that do not respond to conventional treatments. The combined use of the two drugs was associated with greater levels of clobazam in plasma and an increase in its side effects, following a typical pattern of excess dosage. These were easily reduced by lowering the dose of this compound. It is therefore important that patients who use cannabis for medical purposes report to their doctor to enable them to take these possible interactions into account and, if necessary, adjust the dosage of any treatment they are receiving. Another issue that requires further analysis is the possible interference between cannabinoid treatments containing CBD and antioxidant supplements. This cannabinoid produces anti-tumor responses in different cell and animal models of cancer. Although the molecular mechanisms by which this effect occurs are varied, one of the ones that appears to have greatest weight is the generation of reactive oxygen species, precisely the type of compounds on which antioxidants exercise an effect. Therefore, one might consider whether the antioxidant supplements could interfere with the potential anti-tumor action of CBD. Indeed, the use of antioxidants during the anti-tumor therapy is still controversial among oncologists. On the one hand, the toxic effects of non-tumor cells of oxidative stress, generated by the tumors themselves or by the therapy, could be countered with antioxidant supplements. However, these supplements may block the harmful effects of the oxidative stress on the tumor cells. For the time being, the consensus appears to be that there is still not enough scientific evidence to support the use of antioxidants in cancer patients during anti-tumor treatments. Finally, another issue that requires additional study is the use of cannabis during treatment with immunotherapy. This is a type of therapeutic strategy that is increasingly being used in the area of oncology. Its ultimate aim is to stimulate the patient's immune response so that it destroys the tumor cells. It has been widely demonstrated that different elements of the immune system, B and T lymphocytes, macrophages, monocytes, etc., possess a functional endocannabinoid system, which exercises immunomodulating effects. Results from some preclinical and clinical studies indicate that cannabinoids exercise immunosuppressant effects, which could pose a potential problem when cannabis treatments are combined with immunotherapy. However, there is no evidence whatsoever that the use, even chronic, of cannabis is associated with the appearance or aggravation of infectious diseases or tumors, even in immunocompromised individuals such as, for example, HIV patients. In any case, more research, both preclinical and clinical, is urgently needed to resolve all these queries and in order to be able to offer rigorous information to both patients and the health professionals who accompany them in their treatments. This article was brought to you by Fundación Cana.